Dr. Manisha Agarwal. She will be speaking on imaging in diagnosis and management. Dr. Manisha is the currently Secretary of Vitreoretina Society and doing a very good job. Dr. Manisha.
Thank you, sir. A very good morning to all of you. Imaging modalities in diabetic retinopathy are of significant utility, all for screening, evaluation, diagnosis, as well as management of diabetic retinopathy. And different imaging techniques can be useful depending on the manifestation or the stage of the DR that we are dealing with. So in our armamentarium, we have color fundus photography, fundus fluorescein angiography, and ultrasound, OCT, and last but not the least, we have optical coherence tomography angiography. So as far as the color fundus photography is concerned, this is very helpful for screening and for documentation of DR, as well as for counseling our patients when they visit our clinics. It is also useful for monitoring the progression of DR. And there are different types of fundus photography which is available. We can have a standard, we can have a wide field, and also now we have the ultra wide field which provides a 200-degree snap in one go. Screening for DR outside the ophthalmic clinics is always a challenge, and I think Dr. Kim really spoke about it. And what we are now targeting is that we should not only limit the screening of DR in ophthalmic clinics, but also target the physicians and the diabetologists. And this can be very well done using the non-mydriatic fundus cameras with AI and also using telemedicine. The advantage being that it is an easier access, a better compliance, as these screenings can be done at primary healthcare provider clinics there itself. And this is a slide I borrowed from Dr. Kim, who Arvind Eye Hospital and SN both are grossly involved with screening of patients for diabetic retinopathy. And as rightly shown, that when we are using tele-screening, the turnaround time can be around 1 hour. But when we are using an AI tool, it can be reduced to as short a time as 1 minute. Coming to fundus fluorescein angiography, we all realize that it's an invasive procedure. However, it still remains the gold standard for managing a patient of diabetic retinopathy. And the indications being that it helps to diagnose proliferative stage of diabetic retinopathy, when we are suspecting macular ischemia, planning macular laser treatment, in patients with asteroid hyalosis, and also for identifying the capillary non-perfusion areas. So though the classical teaching is that we would advocate a laser treatment when the patient has reached a stage of PDR, but many a time these patients may not be able to come back for a regular follow-up. And then the patients with a severe NPDR with extensive CNP areas also can be advised a laser photocoagulation to avoid a sight-threatening stage of DR. This is a wide field angiography, and it reveals much more than a normal angiogram, and you would see that in a normal angiogram, you're able to assess only the central part, but many a times you may have the pathology lying in the far periphery, which is much better picked up on a wide field angio. This is, again, a wide field FFA, which is showing that there are extensive CNP areas and persistent neovascularization, which is in the far periphery, requiring addition of laser photocoagulation. Coming to OCT and its role in DR, it's again a non-invasive test, and so it is very much easily doable in our clinics. It helps in quantitative assessment of diabetic macular edema in the form of assessment of macular thickness. And we can also do a qualitative assessment of DME, whether it's central involving or non-central involving DME, and what's the type of DME that we are dealing with. And also it can help in assessing the response to the treatment and detection of recurrence of macular edema. We have various kinds of OCT biomarkers for DMEs, and the most common ones that we really assess and have a clinical implication is the epiretinal membrane, neurosensory detachment, a droll, hyperreflective foci, the choroidal thickness, and they all are said to influence our treatment decision, whether we would like to treat our patients with anti-VEGF, steroids, or a surgical intervention. And all these biomarkers, of course, have a role to play when we are wanting to prognosticate our patients. So here we have a thick posterior hyaloid phase, which is causing a traction on the posterior pole of the retina. And here, whatever agent you may try as an intravitreal injection, it's unlikely to have a benefit because all the inflammatory mediators, they tend to collect in between the posterior hyaloid and the retina. And where any pharmacotherapy is unable to really penetrate. And these are the patients who would ultimately require a surgical intervention. There's another term called as disorganization of the inner retinal layers, and this is basically to identify any kind of an ischemic insult to the retina. And this is how we identify a drill while we are doing an OCT, and this corresponds very well to macular ischemia, which is seen on FFA and OCTA. However, what we need to understand and remember is that we have to continue the treatment as it is reversible. It correlates well with the visual acuity and also helps to prognosticate the patient. A drool is a bad prognostic sign because it tells us that there has been a damage to the photoreceptors, and these patients are unlikely to recover the vision. Hyperreflective foci are basically inflammatory cells, and therefore these are the patients who are going to respond better to an intravitreal injection of steroid rather than anti-VEGF. And a subfoveal detachment again tells us that these are patients who are going to be responding better to an intervention with steroids rather than anti-VEGF, and because it signifies a higher collection of inflammatory cytokines in the vitreous. OCTA, on the other side, is again a non-invasive tool, both for qualitative and quantitative assessment of the macula, including macular ischemia. It is able to identify various signs of diabetic retinopathy and also helps us in various metrics assessments such as vessel density, foveal avascular zone, and the areas of non-perfusion. It also helps us to monitor the progression of diabetic retinopathy. Microaneurysms, of course, is a feature of DR, which is basically said to be a slower flow speed pathology, and therefore it is better picked up on a fundus fluorescein angiography rather than on an OCTA. And that is how we need to understand that both FFA and OCTA are going to be basically complementing each other. IRMA is visualized on NFAS images, and they appear as dilated or looping vessels near the areas of CNP. The caliber of these loops is noticeably greater than that in the surrounding area. We can also image the neovascularization, and it basically is going to be identified by the disruption of the ILM. Flow signals above the ILM will help us to differentiate between NVE and IRMA. The advantage of OCTA is it picks up very subtle NVEs which may not be detected on FFA. It also helps in precise measurement and monitoring of the size of NVE is possible, which is maybe obscured by the leakage on a fundus fluorescein angiography. The disadvantage is that if there are very elevated NVEs beyond the margin of the ILM, they may appear as shadows rather than a flow area. So here, these are a few of my images where you see that on a color fundus photo, you are able to identify NVEs, and on doing an OCTA, again, you are able to pick up the same areas, which beautifully, again, is going to be helping you pick up NVE in a non-invasive manner. This is a comparison between OCTA and FFA, where you can again identify the NVE areas. And this is a patient of asteroid hyalosis, where again on OCTA you can identify the details of the fundus. So OCTA basically helps in monitoring the regression of neovascularization. No changes found in the density of superficial or deep capillary plexus. And this is a color fundus photo, OCTA and FFA, where again pre and post laser you can identify the regression of the neovascularization very beautifully, again, which is very well seen on an OCTA image. This shows the active neovascularization above the ILM, which has shown a beautiful regression again after doing the laser treatment. You can also pick up macular ischemia by enlargement of the foveal avascular zone, and thus you can actually monitor the progression of changes of diabetic retinopathy by a non-invasive tool such as OCTA. The future holds in recognition of subclinical diabetic retinopathy, and OCTA may offer an opportunity to detect DR when subclinical in a non-invasive way, and this may impact our follow-up. And very subtle changes such as decrease in the deep plexus, vessel density, enlargement of FAS, A decrease in the parafoveal vessel density in both superficial and deep vascular layers and impairment of the choriocapillaris flow may be very subtle changes which can be picked up and helping us in identifying subclinical DR. A wide field OCTA in a patient with no clinically evident diabetic retinopathy again can really pick up the changes which are happening in the far periphery. Therefore, to conclude, color fundus photo helps in screening for DR even outside ophthalmic clinics using teleophthalmology and AI-based cameras. Multimodal imaging, including FFA, OCT, and OCTA, helps in evaluation, prognostication, and management of DR. Wide field imaging may help in identifying the peripheral retina changes and early diagnosis of DR. And OCTA may help us in future to pick up subclinical changes of diabetic retinopathy. Thank you so much.